if you or someone you know has been diagnosed with a disc bulge or herniation, you probably have understood that the pain, whether it's in the lower back, can affect just the lower back, or maybe it goes into the hip or the groin. Sometimes it goes down the leg. It can affect all the way to the foot. There can be numbness or tingling or burning sensation. If the disc bulge or herniation is being diagnosed in the neck area, then this can sometimes just affect the neck. It can also sometimes affect all the way to the head with headaches. It certainly can affect the shoulder down through the elbow to the hands. Sometimes, again, there's numbness, tingling, burning. And very often it affects muscles as well, either in the function or coordination, or also with muscle weakness. So what we want to do, first of all, is talk about how this can then affect you with regards to what you're doing at work or maybe with exercise. Some people have trouble with knowing what types of exercises to do that would help the condition. Some people want to know whether what they're doing at work, whether it's prolonged sitting or standing, or if they're doing more physically active types of things, whether this can affect them and whether they should be doing that or not. Some people have trouble with sleeping because of the disc problem, or some people just wake up with more problems in the morning and then wonder whether there's a sleeping position that affects them as well. So we're going to go into what the disc herniation or bulge is, and then we're going to talk about why there are various different types of treatment based on knowing which in that spectrum of bulge or herniation is affecting you. So in diagnosing or looking at or trying to figure out where your disc bulge or herniation lies on that spectrum, the first step is doing a health history. And in the health history, we want to know about any past treatments that you've had, if you've had any x-rays or MRIs. We also want to talk about what's occurred in the past with regards to physical injuries or traumas. Sometimes disc bulges and herniations will start with an event very early on in life, and the pain will completely go away, and then it will slowly come back little by little after many months or sometimes even years. And we're going to talk about why that occurs, but that's certainly something that we want to know in the health history. In the physical exam, what we're looking for are things like posture and muscle imbalances, because certainly if a person has problems with regards to muscle imbalances or curvatures in their spine, or sometimes they even may have arthritis, those can overlay or amplify or affect the way that you would treat the disc bulge or herniation. So what we're trying to sort out in the physical exam is to what extent the disc bulge or herniation is affecting someone, as well as what may other conditions affect that particular condition as well. So we're going to be looking for muscle strength, whether there's decreased sensation. Sometimes, unfortunately, nerves will affect organs, and so we want to know about that as well. Particularly for the lower back, there could be bowel or bladder conditions that are affected by that, and sometimes the nerves in the upper spine can affect other critical areas. So we're going to go through a complete health history and do the physical exam. The next step has to do with diagnostic tests, and certainly x-rays can show us whether you have arthritis. But the key test for most disc bulges and herniations is the MRI. Now, because MRI is a very evolving technology, what we're getting is there are various differences in the quality of the machine, specifically the size of the magnet. We're also going to talk about the position of the MRI, because there's what's called positional MRI, where a person could be seated rather than laying down. They could also be bent forward in a flexed position or extended to see how that affects the disc. The second part of the MRI is the software or the technology with regards to how that particular machine is going to look at the MRI. And unfortunately, there are various qualities of software and application of that software that will then have an effect on the result. So, for example, according to the College of Radiology, the American College of Radiology, there are various slice thicknesses to look at the degree of how many slices occur to look at the disc. The second part of the software is the angle. Unfortunately, because people have different curvatures in their spine, sometimes the angle at which the MRI is taken can sometimes miss the disc herniation. And then finally, we're going to talk about the interpretation of the MRI. You'd like to think that everybody was on the same page with regards to looking at MRI and describing it, but unfortunately, according to research, 42% of the time the radiologist that's reading the MRI is actually missing or saying something different than someone else with regards to the shape and the size. And then you get into, and unfortunately it's a comedy of errors, when you have this communication down the chain of command from, say, a radiologist to your general practitioner, and then maybe to a physical therapist, or if you're doing personal training, maybe that's being communicated as well. So there's misinterpretations of that communication with regards to what the problem actually is. So the ideal scene is that the same person that reads the MRI is aware of how the MRI was taken, the type of machine, so that then they can apply the type of treatment that's ideal for you.